Welcome to the ABCs of MIPS, our monthly broadcast looking at how merit-based incentive payments will impact your bottom line. I'm Carol Flagg of High Tech Answers. Thanks for tuning in today. On this program, we address your questions covering the full spectrum of the payment program alphabet. And on today's program, our expert addresses MIPS for participants in alternative payment models. Our expert from SA Ignite is no stranger to the ABCs of MIPS. He is Tom Lee, the founder and CEO of SA Ignite. Tom is a serial entrepreneur and leading expert in healthcare value-based programs such as MIPS, MACRA, Meaningful Use, and PQRS. You can contact him at tom@saignite.com. Tom, how are you?
I'm good, Carol. Good to be here. Hope you're well too.
I am. I'm going to go ahead and go on mute and then turn this presentation over to you, and I'll see you back on the Q&A.
All right, that sounds great. Well, it's great to be back. I know you all were in very capable hands of my colleague Beth for the last couple months, and I wanted to kind of recap a bit to sort of bring everyone to the same sort of update where Beth really left us off was really around what you can do now about MIPS, regarding MIPS. And actually one update that she wanted me to share with you all is that we actually have coming very soon from our website a free ACI score calculator that was actually used to deliver some of the results that she showed you all in terms of how the ACI scoring works. And this calculator we're really excited about. It gives you a really easy way to see what your ACI score may very well be based on your existing meaningful use measure values, and we take care of all of the scoring and the other aspects of that. So look for that. It should be coming out through the as an email notification very shortly. So really, since we last convened, the big news was really the closing of the comment period for MACRA. Ended June 27th. There were over 3,800 unique comments that were submitted. And of course, the big follow-on news from that was really news that CMS is considering what obviously was one of the biggest common areas was around delaying the start of the program or altering the reporting window. I think generally what I'm seeing out there is provider organizations, of course, they would appreciate some relief on that, but really don't really see any material slowdown in folks' efforts to really start getting prepared for MIPS and the APM side. As a recap, some of the high areas of comments, a number of us have reviewed most, if not all, the comments from the major organizations. Beyond the start date of the program performance period flexibility, also a lot of talk around some sort of relief for the small practices and rural providers that are currently projected to be potentially financially at risk more than other organizations under MIPS. Also, a lot of comments around how the quality and the ACI reporting requirements are really going to be finalized, and what the scoring, some really things around like the edges of the scoring algorithms, how that's going to work. Great lead into today is a lot of the comments as well around advanced APMs, and we'll go through the terminology set in a moment as a background point so we can really dive into that. And then in particular, what we're really going to focus on today is there's this interesting boundary between MIPS and APMs, and it's basically MIPS for APMs. And for those of you who've had a chance to look at the rule or have heard about this, it is truly one of the most complicated parts of MACRA, and it clearly impacts many Medicare ACOs as well as other types of APMs that are bound to be growing in popularity in the coming years. So that's really where we're going to focus. And here's how I have it broken down is, first is some level setting regarding, why is it that an APM clinician could still also be subject to MIPS? Why is that? And then really going into the question of how do you determine whether any particular advanced APM clinician will be subject to MIPS. And we'll talk a lot about the difference between advanced versus non-advanced APM and what are some of the consequences of that. And then we're also going to go into this particular phrase called MIPS APMs, which is defined within the MACRA proposed rule, which really refers to this scenario where certain types of APM entities will be subject to MIPS, but really a constrained version of MIPS that varies, that differs from the full MIPS, with respect to scoring as well as what the reporting requirements are. And so today, be prepared. This will be a little bit more of me pushing information to you all, and we hope to have some decent time for Q&A at the end, but it might be a little bit shorter than usual, all right, in the interest of trying to get the information to you. It is a very complex topic. Don't be surprised if you need to look at this again. It'll all be posted as usual, and let's get right into it. So why is it that an APM clinician can still be subject to MIPS? So in order to understand that, let's first look at how MACRA is broken up. So you have the two main tracks of MACRA, MIPS as well as the alternative payment models, the APMs. And then within the APMs, there's another distinction between those APMs that are considered to be advanced and those that are non-advanced. And it's only those APMs that are considered to be advanced that really have any opportunity for the entities that participate in that advanced APM to be able to get the 5% annual bonus, as well as to be exempt from MIPS. But there's gray area there, which really underlies the discussion today, is where is that overlap then between these two tracks? Now, in order to understand that, we're going to go through some of the unit relationships that are important to understand this question around APM. These are basic definitions that's really important to understand what they are and then how they relate to each other. And then you'll then see why it is that these relationships are actually what drive a lot of complexity in the MIPS APM and just APM rules in general. So first, let's talk about the term APM, alternative payment model. Literally what it is, it's the name of a program. So for example, the Medicare Shared Savings Program is one. The Next Generation ACO program is another. They all must be defined by CMS. So the term APM technically does not refer to any value-based program that is created by any other entity other than CMS. That's the first thing to really understand about that. That often is a source of confusion. The next level below that is, okay, every APM, such as the MSSP program, has a number of APM entities that have contracted with CMS under that program to participate in it. So for example, it would be an ACO entity for the Shared Savings Program. If we go to the next level, is that many of these APMs have mechanisms by which groups of providers can participate in that entity. So an example of that is within the Shared Savings ACO program, it's really the tax ID. Groups that are defined by a particular tax ID or TIN number that bill towards Medicare, where different TINs have the ability to contract with the ACO entity or the APM entity more generically, and thereby be subject to all its requirements and its incentives and quality reporting and all that type of stuff. The important thing to note about this is that it is a many-to-many relationship between the entity and the group. In other words, one particular group or one TIN may very well enroll in multiple APM entities, where those APM entities may in turn be in completely different APMs. So an example is that recently CMS provided guidance that TINs or groups that were really participating in the Shared Savings Program now have the ability to also participate in the forthcoming Comprehensive Primary Care Plus program or CPC Plus program, whereas previously that was prohibited to be participating in two different APMs that way. Now it's allowed. Okay, so you're going to see more and more of this type of situation where one TIN may actually be participating in multiple APMs as that starts to get rolled out. Okay, so that's why this is a many-to-many relationship. Now going even further, really it's when we talk about who's paying or who's really filing the claims for the services delivered, it's most often at the TIN level. So it's the group that's actually submitting the claims and actually being paid Medicare Part B payments by CMS. That certainly is the primary target for MACRA. It's all about Part B payment adjustment. Okay? Almost done here. The next level is really down to clinician level. So another many-to-many relationship, clinician defined by that NPI number, And a clinician may not only be billing Part B claims through one TIN, but may also be billing through multiple TINs. So think of a specialist, for example, that may be contracted with multiple TINs. Maybe some of those TINs are in an APM entity and maybe some are not. And that's all allowed for in the way that the rules are set up. So it's yet another many-to-many relationship there to kind of bear in mind. And then finally is down to the patient and beneficiary level. And again, there's a many-to-many relationship there. The patient is identified by an HICN number by Medicare uniquely, but that patient may very well be obviously seeing many different clinicians, and one clinician obviously needs to see very many patients. So there's a lot of many-to-many relationships here. And if you think about when you really go and try to absorb the APM and the MIPS APM regulations, this mental model is very useful to have, because you really want to make sure that when you read any particular phrase in that regulation, you want to make sure at which level are they talking about. Are they talking about a requirement that's being placed on an APM entity, for example, or a requirement that's being placed on a TIN, or even on an individual provider, or even on the entire APM, because APM as a program must be qualified by CMS to either be advanced or not advanced. And there's all these rules around this. And probably one of the biggest sources of confusion around understanding this regulation is then when reading the APM provisions, people are not necessarily, they don't necessarily have this mental model in mind, and they start basically thinking certain requirements apply to different other levels when in fact it only applies to one level. Okay, so if there's any kind of one takeaway you can get about this to go off and study more on your own, it is that fact that this slide is probably the most important one to really understand, okay? Now that being said, it is what it is. So these many-to-many relationships, it's a fact of life, and really the fact that these are many-to-many relationships actually drive a lot of the complexities in the rules around how MIPS applies to APMs. That's a lot of the root cause, is the fact that there's these many-to-many relationships that you have to deal with and understand, okay? But once you grasp this model, the rule becomes a lot easier to understand. And so hopefully I'll lead you down that path right now. So first is that question, why can a clinician be subject to MIPS at all, an APM clinician? And that really goes back to, remember, MIPS is the default. And there's really only 4 ways to be exempt from MIPS. The first, and kind of one that we just almost take for granted, is that a provider, a clinician, has to meet the eligibility credentials. So for example, for the 2017 performance year, if a provider is not any one of these particular professions and credentials, then they're not even in MIPS. Now, in 2019, that expands much more in the way to be more like what PTRS is, say, from an eligibility standpoint. But first 2 years, it's more restricted. That's an easy way to get out of MIPS right there. The next 2 we've talked about before are for first-year Medicare clinicians or for low-volume clinicians that are both billing less than or equal to $10,000 per year in Part B, as well as they're seeing less than or equal to 100 Part B patients. These numbers might undergo some change in the final rule, and we'll see how that lands. Okay, but that's what's currently been proposed. And then the final one, which is of interest to us today, is really providers that are showing quote-unquote significant participation in an advanced APM. And very specifically, it's actually APM entities that are each showing significant participation that can confer upon their clinicians the ability to be completely exempt from MIPS, okay? So this significant participation, when you see the word participation in advanced APM, be very cognizant of the fact that we're talking about the entity, whether the entity is participating at a high enough level, and then if it is, then all these organizations below, these clinicians below, are going to inherit the determination of participation for the whole entity. Okay, so we'll come back to that over and over. That's also an important takeaway from this, from this talk here. So really, bottom line is that to kind of restate this participation concept is clinicians in those APM entities where the APM entity may be falling below certain participation thresholds in an advanced APM, and we'll get more into what those thresholds are. Those clinicians are then subject either to the entire MIPS rule set or a constrained version of MIPS, which we'll also talk more about. And so really clinicians that fall into this category, or entities rather that fall into this category of not meeting these thresholds, we've created a term that we just use here internally, which is called insufficient participation. And we're going to really explore now the circumstances and implications of insufficient participation of an entity in an advanced APM where they would otherwise have an exemption to MIPS and get the 5%. But in particular, we're going to talk about exemption to MIPS. If they were above that threshold, then they would be fine, but they're insufficient. So what does that really mean? Okay, so now what I want to do is, sort of in light of that knowledge, I kind of want to go back to this diagram of how MIPS and APMs are laid out relative to MACRA. And as I just showed you previously, the reasons why it's possible for an APM clinician to have to do MIPS, we're now going to talk about the different ways in which they'd then be required to participate in MIPS. And really, as a way of fundamentally, I think in many ways trying to make it simpler for those APMs that, or those APM entities that kind of have that unpleasant surprise that they're going to have to do MIPS as well, that CMS created this concept called MIPS APM, which is essentially a synonym for a constrained version of MIPS that in many respects is easier than regular or full MIPS, but in some ways actually could be more difficult. Okay, and we'll actually go through some examples of that. And so really this is where you start creating that gray boundary, that sort of that zone between MIPS and APMs, is really with these two concepts of some APM entities and their clinicians are going to be responsible for a constrained version of MIPS in addition to their APM responsibilities, and others, lo and behold, may actually have to do the entire MIPS set. Then the way in which CMS has laid this out, there's actually a famous Table 32 on page 501 that actually lays it out, is in terms of which currently defined APMs are falling into these two different categories, as well as which of those APMs have been determined by CMS or proposed to be an advanced APM versus a non-advanced APM. Okay? Now I want to start with the simpler one, which is the non-advanced APM. And basically non-advanced APM is the biggest area of discussion and comment has been that one requirement to be an advanced APM instead of a non-advanced one is an advanced APM has to bear a more than nominal amount of downward financial risk, which CMS has currently defined as revenue risk as opposed to investment risk. Okay, not a cost risk, but your revenue could go down if you don't perform well. And so as a result of that definition, there's a number of APMs that don't cross that threshold for advanced APMs that have therefore been fallen back into being non-advanced APMs. An example that's most prominent are the Track 1 ACOs, the Shared Savings Program, and there's a couple of other programs. The oncology program, where it's a one-sided, where there's incentive only, also falls into this category. And for anyone that's in this category, those providers, all of those clinicians are going to have to either do constrained MIPS or the full MIPS. So really the folks down here in the lower right-hand corner, BPCI, joint replacement, right now CMS has classified these APMs as not only being non-advanced, but also having to do the full MIPS set. And that obviously has generated a lot of comments into the draft rule from these constituencies to try to really get some relief or get some reclassification, and that remains to be seen how that's going to play out. Okay. So really, the thing here is that the determination of whether any APM is advanced or not, and whether any APM is going to benefit from constrained MIPS or not, these are two separate decisions and two separate determinations by CMS. And so theoretically, it is possible that there could be some APM in the future, although it's unlikely, it's still theoretically possible based on the way the regulation is written, that you could have in the future an advanced APM that for providers, for entities that are participating enough, significant participation, that they will benefit from the 5% annual bonus and MIPS exemption. But if there are APM entities in those future advanced APMs that are not participating enough in that APM, that advanced APM, that those providers are going to have, or those entities are going to have to do full MIPS. Okay, so it'll be interesting to make sure that those, see how those are people who are designing APMs, the new wave of APMs, should be keenly aware of the fact that they really at worst want to end up here, not down here. Because down here, if it means that there is going to be insufficient participation by some of their entities, they're going to have to do full MIPS rather than do constrained MIPS. All right, and we'll kind of go into a little bit more about that, but this is a really interesting area that those who designed APMs need to be more and more aware of. Okay, so I know we're getting very technical here, but I feel a little bit better, and I gave you all some idea that this might be one of those things you have to look at again. Okay, so now what I want to do is talk about, well, what does this MIPS APM thing really mean? This constrained MIPS, what does that really mean? And the first question is, well, how is an APM really deemed to be a MIPS APM? So this goes back to folks who actually are designing APMs, and I just want to give you a sense of what they need to face. All right, so that at an operational level, you kind of know the whys behind why certain requirements are being placed upon you. And so really what it comes down to, and this is in the regulation where it basically says, okay, what is an APM? What are the additional requirements an APM has to fulfill in order to also benefit from doing a constrained version of MIPS rather than the full MIPS? And it really comes down to these things. The areas we're going to focus on is that APM, it has to measure performance on cost and quality. And there's some APMs that only do one or the other. You got to do both. And then in particular, there's certain APMs, such as CJR, that because they're facility-based, they are not able to benefit from MIPS APM. Okay, so it's this phrase that explains why these folks are really down here rather than being up here. And that is an area of a lot of comment into the draft rule, and we'll see how CMS resolves that. Okay, so this is how you kind of get into that MIPS APM classification as an APM, as a program, entire program. That's how you get put into one bucket or the other from a program level. So what I'm going to show you now is kind of a summary. I'm trying to recap all of what I just described to you in one Venn diagram. Okay, for those of you who may remember doing set algebra in grade school or junior high. So for those APM programs that meet the MIPS APM standard, that meet these previous standards here I just showed, then those APMs, you can have ones that are either advanced or non-advanced. And then when you then really look at the clinicians that are within the APM entities that are really participating in these two different types of APMs, then you have this situation where there may be some clinicians there in advanced APMs entities, and those entities are insufficiently participating in the advanced APM, and therefore they're going to be subject to constrained MIPS, just like all of the non-advanced APMs are going to have to be subject to it. Okay, so that's basically in a nutshell what I just described in the last couple slides. And then similarly, for the full APM, so those APMs are following that lower row of the last table I showed you, where those APMs are not meeting the MIPS APM standards. They have to go through full APMs. Then you have a similar situation where, again, you can have certain advanced APMs, because of their insufficient participation, that they're now going to have to do full MIPS. Okay. All right. Well, so how do you determine which of these advanced APM entities are going to have to do constrained MIPS? What determines whether or not an advanced APM entity falls into this sliver here, either here or here? That's what we're going to talk about now. So determining whether an advanced APM clinician will be subject to MIPS. We're talking about this sliver right here. So I need to provide you yet more background in order to understand this, because without that kind of mental picture, it's really hard to follow in the regulation. So this is my attempt to try to convey to you what it really means. So we're going back and we're using that key unit relationship model that I presented before, where you have an APM, let's say it's a shared savings program, you have a particular entity, so it's an ACO ID, that has a certain set of groups underneath, or TINs, and a certain set of clinicians underneath. And these clinicians, for the purposes of Medicare Part B, are delivering evaluation and management, or E&M services, to, let's say, 3 patients. And they're all Medicare Part B eligible patients. And then, and so really, when we talk about, because we're really trying to get here, is I'm trying to convey how are patients actually attributed to an APM entity, because you have to understand that first in order to understand which clinicians could end up having to do MIPS as well. Okay, it's all about patient attribution. And so for these 3 patients that are receiving, each are receiving at least one E&M service from any particular clinician within this entity. By the virtue of that fact that that patient is receiving that E&M service and it's being billed to Medicare, it means that that patient thereby becomes what's called attribution eligible with respect to being attributed to this entity. In other words, these patients now fall into the candidate list of patients that could be attributed to this entity, but are not necessarily attributed to that entity yet, okay? Because you can't attribute patients just by virtue of the fact that they got at least one E&M service, because what if there are other TINs and APMs that are also serving the same patient? Which of these 3 columns has the greatest amount of responsibility for this patient? Okay, that's the key question. And so every APM has some methodology by which it attributes patients based on, for example, who's providing the most primary care services, or who's, or is there an enrollment list where the patient has to opt in to be considered this to be their home or that to be their home, okay? So whatever it is, and the shared savings program has a very complicated way of doing this. What it means is that there's going to be some denominator here, which is, let's say, going back to, apologies, let me go back here. With respect to this APM, there'll be some patients that are, these 3 patients are candidates or attribution eligible, but maybe it ends up only that this one is actually attributed to this entity. Okay, so then it would be that 1 out of these 3 patients is actually attributed, and that's basically would be a 1/3 ratio, okay, or 1/3 ratio when it comes to what I'm about to show you here. So this is an attribution ratio. This is important. This actually is what technically defines who is going to have to do MIPS and who won't have to do MIPS from an entity, APM entity standpoint. And so what CMS has defined is there's actually 2 alternate ways for you to prove that that your entity is participating enough in the advanced APM to get an exemption entirely from MIPS. And it's defined as either the payment amount method or the patient count method. And the payment amount is what they do is for all of those attribution eligible patients, they add up all the Part B payments across all all clinicians and entities that the patients are incurring. And then they divide into the Part B payment amount only for those patients that are actually attributed to that particular entity. And you come up with a ratio, okay, and same for the patient count. And then an example is that, using an example from the previous slide with the 3 patients X, Y, and Z, is, for example, if you had patients X and Y that were attributed to entity 1 and patient Z that was attributed to entity 2, then these are the ratios you would come up for the patient count value, okay? So entity 1 would have a 2/3 ratio where 2 out of those 3 patients are being attributed to it, and whereas entity 2 only has a 1 out of the 3, and they get 33%. So these percentages are actually the key metrics that are going to help determine whether or not that APM entity is going to be exempt from MIPS or not. In other words, whether they're sufficiently or insufficiently participating in that APM model. Okay? I won't be surprised if half of you all are thoroughly confused at this point. I know I was, and it takes a while to get it, okay? So again, I encourage you to relook at this again or reach out with questions or take another look at the regulation. There's references here, page references you can take a look at, and certainly track things as they get finalized in the final rule. The earlier you can understand some of these parts, the more you're going to be able to quickly get your hands around the final rule when it comes out, because many ACOs and others are not going to have a lot of time to figure out how it works before they have to start making some decisions. Okay, so here are the thresholds that you have to reach. It's very simple, actually. Once you get through that complexity, it's a very simple rule, is that an APM entity is deemed to be insufficiently participating and thereby subject to MIPS or constrained MIPS if both of these conditions are true. In other words, if they both, is that the payment amount threshold is less than 20% and the patient count threshold is less than 20%. If either one of these is not true, in other words, they're exceeding threshold on either of these, then they will be deemed to be significantly participating and thereby will be completely exempt from MIPS as an APM entity, okay? And all their clinicians underneath are just going to inherit that benefit. If, on the other hand, the entity is deemed to be insufficiently participating, then all the clinicians below it will also be deemed to be insufficiently participating, and they're going to inherit the bad news as well, okay? Or depending on your perspective, bad news or that news will apply to them as well, okay? That basically just writes what I just said there. And for those of you who are real policy wonks that really kind of read through the rule, this insufficient participation concept that we've introduced here, or at least put a name on it, in the macro rule, what it really means is that you're not a qualifying nor partial qualifying participant in an advanced APM. That's an exact synonym to what we're calling insufficient participation. All right. Okay, so, you know, before I kind of get into the so what, like what's the impact of this? All right, I want to just highlight one thing that has been a subject of a lot of comments within, particularly from major organizations, that is, I think, identifying a real timing issue with the way that CMS has laid this out so far. And you know, perhaps there's some ambiguity there and the words didn't quite reflect the intent and things like that. They'll all be clarified in the final rule. But I want you all to understand that there is a real potential disconnect here that is causing a lot of consternation. And that is this timeline. Is that if you think of 2017 as the first performance year, and then the subsequent end of March is when you have to submit your MIPS data if you're either subject to full MIPS or constrained MIPS. It's March 31st across the board. That's relatively uncontroversial. But the problem is that CMS is not going to tell these advanced APM entities, whether or not they're insufficiently participating until at the earliest May. Okay, and they basically say likely no earlier than summer, because it takes CMS a while to look at this performance year and look at how the payments are flowing, look at how patients are attributed, to have any kind of final way of calculating those payment count and payment amount metrics to compare against threshold to determine whether or not the provider's insufficient, the entity is insufficiently participating, and thereby is subject to MIPS. So for those of you who are looking at this, you probably see a real problem here. And I'll just put it in words, is that what it means is that prior to the deadline for submitting data, under the way the rule is currently drafted, advanced APM entities are going to have to somehow predict on their own whether or not they think CMS is going to be deemed them to be insufficiently participating, so that if they are predicting that they will not meet those thresholds, they're going to have to go ahead and track MIPS throughout this whole year, or as much of it as possible, and submit data on time just like every other MIPS clinician or entity. Okay, so this is a real problem that I know CMS is looking very close at, but it's something to definitely look for in the final rule. Is how are they going to resolve this or provide some relief around this is a very key issue. Otherwise, you can have a lot of APMs that are going to have to be tracking MIPS if they really want to do it right and be careful and be conservative. They're going to have to be tracking MIPS to a very great extent, even if it turns out that they are sufficiently participating. But they're not going to find that out until after this MIPS submission deadline. All right. So eye on time here. I think we're doing pretty good. And again, we'll try to have some time for questions at the end, but I do apologize ahead of time if we run out of time for our full Q&A. So really, I want to bring you all home right now. Is what's the big fuss with this? You know, what's the impact of someone having to do MIPS as well as APM? Well, if a provider is in APM and they are actually subject to full MIPS, such as the CJR folks, then that is obviously a huge concern because they have to do the full MIPS set and they have to worry about APMs with no relief on the MIPS side. They'll be just like any other MIPS clinician or any other MIPS group. So that's kind of easy to understand. And so I'm really going to put that to the side right now. I'm going to focus on the constrained MIPS. So the Track 1 shared savings ACOs, for example, they're going to have this special a flavor of constrained MIPS. What does that look like? What are the advantages of that? And what might be some of the concerns about that from a scoring and a reporting standpoint? So let's go into this MIPS APM case. So again, we're really focusing on this row right now. These folks, what does it look like for them? Okay, so pause and kind of just catch your breath for a moment because I now need to introduce yet another categorization scheme for APMs in order for you to understand what is the impact if you're in one of these programs. And it's basically what CMS has done is they've essentially looked at the ways in which these APMs are currently reporting things like quality. And they're trying to make it as easy as possible for those folks by creating 3 different types or categories you got to think of. One are the shared savings ACOs. The second are the next generation ACOs, which is the follow-on ACO program at CMS. And then the third is all other APMs under these models. Whatever those other ones, just one single bucket for all of the rest of them. And depending on which of these 3 types you're in, will determine what flavor of constrained MIPS is going to apply to you. Okay, and that's what I want to really spend some time on now. And there's going to be references here you can look at in the rule yourself. Okay, but as a level set, just remind everyone, for a regular full MIPS clinician, here are the performance categories, and here are the performance weights across the different categories. And I'm sure this is the 10th time that you've seen this, so I won't spend a lot of time here. But what we are going to do is we're going to go through each of these categories, and I'm going to try to convey to you from the draft rule what it says about each of the 3 flavors of constrained MIPS and what it means in each of these categories for those different types of APM entities. That's what I'm going to attempt to do here. So first off is I want to recap just some general rules when it comes to MIPS applied to APMs just to kind of keep in mind. All right, the first is that you're going to see cases where a performance category weight has been set to 0%. And what the rule says whenever that happens is that, for example, you're going to see where this gets set to 0%. It means that these 10 point weightings are going to get redistributed to other categories in the way that I'll show you. Okay, so that's kind of principle number 1. That's generally the way it works when the category is deemed to be exempt or when it's just set to 0 by CMS. The other we've hammered home is that the clinicians are individually going to inherit the same composite performance for MIPS as is determined for the entire APM entity. So not only is the determination of insufficient participation made at the APM entity level, but that APM entity is going to get a single MIPS score and all the clinicians are going to inherit it. So you could have one APM entity with 10 TINs under it, and each TIN has 50 providers. And so all 500 of those clinicians are going to inherit the one single MIPS score that the whole APM entity gets. And the reason why that is because a lot of APM programs, for good reason, are trying to score the entire APM entity together because often they're trying to coordinate care and it makes sense to just rate everyone as a group rather than trying to pick it apart. Lastly, and this goes to the multiplicity question again, the many-to-many relationship, right? Well, I mentioned that drives a lot of complexity in these rules. Here's an example of that. So you have to consider a case where a clinician belongs to more than one APM entity. It could be part of a CPC Plus entity as well as part of a shared savings ACO. Well, in that case, both of those entities are being scored. They could be scored on MIPS. So which score applies to that clinician? And CMS here is doing a favor where CMS will make that determination, and they will give the clinician the highest of the 2 entity scores for MIPS that are determined for those 2 entities. Okay, so that is some area of comfort for those of you who are going to be in that situation. All right, now what I do is sort of wrap up kind of the home stretch here. We want to go through category by category and show you what these different flavors look like. So for the resource use category, really simple, 0% weight for all 3 of these types. And it's because these APMs are generally already measuring clinicians on resource use compared to benchmark. within the APM program itself, so no need to replicate and be redundant and do it within MIPS as well, so therefore CMS has set all that to 0%. That is obviously a non-controversial part of the rule. It's highly likely to be in the final rule. Second category is quality. And I think this is relatively straightforward too, but I think it starts to set the stage a little bit for the other two categories, which are more complicated. So for the quality category, which by default is 50% of the score, and you'll see that for the ACOs, it's still 50%. The shared savings ACOs and the next generation ACOs, is they are not going to have to do a duplicate quality data submission because they're already submitting quality data through the ACO program. And in particular, they're using what's called the GPro web interface method. It's a single method that's standardized that they all have to use the same method. So it makes it really simple there. I think one thing that's sort of interesting is from a scoring standpoint is that typically, for those of you who've been on some of our past webinars, particularly the one that my colleague Beth Howe delivered last month, is that for the quality category, usually if you're not in this MIPS APM category, you basically have to take 6 measures for most of the reporting methods, and CMS will only score. We'll take if you report more than 6, they'll score you on your top 6 only. Whereas for these quality measures for ACOs, CMS is going to score all of the measures, and I believe it's 17 measures. So it's more measures being rated on. But I think the more important thing is that these ACOs now have to optimize for 2 different quality scores. So one is the quality score they get from within the ACO program that is based on this data, but the other quality score is the same quality data, but it's being run through a different MIPS quality scoring system. There are some interesting similarities between the 2 different scoring systems, but they're different enough where you could still see material difference in your quality score on a relative basis to your peers through those 2 different programs. So this is, even though it's one data submission, you're still going to get a separate MIPS quality score as an ACO that is separate and distinct from your ACO quality score. And the MIPS quality score is going to adjust your Part B payments in the way that you expect as a MIPS participant. Okay, so that's just a subtlety to kind of keep in mind here, but otherwise, it's pretty straightforward in terms of you don't have to do a duplicate data submission. All right, but the scoring will be separate. Okay, so in the remaining time here, I'll end with the last 2, I would say, most interesting parts of these constrained rules for MIPS. And that has to do with the ACI category and the CPIA category. So the ACI category, it's essentially meaningful use renamed and changed. For a shared savings ACO, you must have one single ACI submission for each of the TINs within the APM entity. Now that is a marked departure from meaningful use today. Because meaningful use today is that there is no notion of aggregating meaningful use metrics across an entire TIN and submitting it as one group submission. And so it'll be interesting in the final rule what kind of clarity about how that's going to be done will come, and the ACO are going to be really focused, particularly the Track 1 ACOs that are really looking at having all their providers, clinicians be accountable for this. There's some operational questions that you can already, I'm sure some of you are already thinking about, well, how is that going to be done? How might it look similar or different from the existing meaningful use attestation process? Those are things that remain to be answered by CMS, okay? Now, okay, so you're going to have, if you have one ACO and it's got 10 TINs under it, you're going to have 10 different submissions. Well, then how do you derive one single ACI score for the entire entity? And that's where CMS says what they're going to do is they're going to do a weighted average of those 10 individual ACI scores for the 10 TINs, and they're going to weight them based on how many MIPS-eligible clinicians are within each of those TINs. Because remember, even that it's always possible to evaluate the MIPS eligibility of any individual clinician. That's always possible. You basically just compare it against the eligibility criteria. that I showed earlier to determine whether that clinician is eligible or not for MIPS. And then they count up those clinicians, and then they do a weighted average, and that ends up being your APM entity level score for ACI, okay, for shared savings, for MSSP. Now, I think what's really interesting is one might think for next generation ACO it would be the same. Why make it different, okay? But it turns out it is different. And most importantly is that for next generation ACOs, they're going to have to submit ACI on an individual clinician basis. They're not going to be able to do it as a TIN. Okay, so this is where it's interesting, is that it's easier, and constrained MIPS is easier in some ways, but this could actually make it harder potentially in some ways, because what if it's easier for a next generation ACO to submit as a group rather than individual clinicians, but they're not allowed to, whereas these shared savings ACOs, they have to do it as a group, and they're not allowed to do it as individual clinicians. Okay, so constraint can be easier, but can also potentially be harder for some people. Depends on your situation. So anyway, the real reason why it's at an individual level here for next generation ACOs is because the way the program is designed is that some clinicians under a TIN may not be participating in the next generation ACO. So of course you would have no reason to report those clinicians either individually or as a group to the ACO program, or under these constrained rules. That clinician would be a separate clinician that'd probably be falling under full MIPS anyway, okay, or doing full MIPS instead of constrained MIPS. Okay, so again, it's the multiplicity of programs and clinicians and their membership in these different entities that causes this type of complexity. All right, almost done here. I'm keeping an eye on the clock. Hopefully we'll have 5 minutes for questions at the end. Now, in terms of the way it's scored, now interestingly, they're not going to do a weighted average of these individual clinician ACI scores based on, let's say, the number of patients they've seen, but they're going to actually do an unweighted average. So they're just going to do a straight average. If you have 100 clinicians, they each have an ACI score of this amount. We're just going to add up all their scores, divide by 100. There's no weighting going on here, whereas up here there is weighting going on here based on the size of the TIN. And for those of you who are real policy wonks, there is commentary in there that explains why it's designed this way. I think it makes for an interesting read if you're interested in it. Okay. And really, for all the other MIPS APMs, they're under these constrained rules. They're going to basically follow this model for the next generation ACOs. Okay, for ACI. All right. So that's ACI, and obviously here you can see the category weights have changed from 25%. This one's really notable, is that for the first year, you're going to have these other MIPS APMs, they're going to get a ton of relief with respect to quality. I forgot to mention is that for the 2017 year, future years to be determined, but for this 2017 year, they're going to give all of these other MIPS APMs a break on quality. They're not giving the break to these ACOs because they're getting their quality data anyway. And the consequence of that is the CMS taking the 50% that it would otherwise here, and they put it all into the ACI category. Okay, so that means ACI is going to be really important for all of these others. So think of CPC, CPC plus. You have entities that don't have sufficient participation. They're going to have to do this, and it's going to count as 75% of their overall MIPS score is going to be the ACI piece. Okay, finally is the CPIA category. Very similar in design to what I just showed you. There is the difference between shared savings ACOs and next generation ACOs in terms of group versus individual clinician submission, weighted versus unweighted average. Differences in the percentage weights, you can see these are up from 15% because of the redistribution of the resource use category. And this is for these other MIPS APMs that are not these two. They're going to have a 25%, which is up from 15%. So in light of all that, again, this is all going to be materials you can look at again, but I just want to go back to this. So if you now really think about these types of APMs, you now, I think, hopefully have a way to kind of draw the connection between this table and really what they're going to have to do from an operational standpoint. And so why don't I end with a summary, and we'll see how much time we have for questions here. So really, the real big takeaway here is that first of all, the non-advanced APMs, such as currently the Track 1 ACOs, are subject to full MIPS or constrained MIPS. The Track 1 ACOs are specifically subject to the constrained MIPS that I just showed you. APM entities that are in advanced APMs, but they're not sufficiently participating, are going to be subject to constrained MIPS, or in the future, potentially full MIPS as well, should there be advanced APMs that don't meet the MIPS APM requirements. And the key thing is that, in some ways it'll be much easier, but in some ways it could potentially be harder, depending on your situation, your infrastructure, how you like to organize yourselves, what your typical reporting habits are, things like that. And then this really relates to the timeline issue I showed, is that for now, the way the draft rule looks is that entities are going to have to start getting some idea of trying to predict whether they're going to have enough participation or not. I think for entities that have a large span of control and they're way above 20 and 10% respectively, they probably have little to worry about. But there's also entities that may be earlier in their life cycle, and in order to find out whether they're going to be over the threshold, they have to have some idea of how much exposure their patients have to Part B payments being billed through TINs or clinicians that are outside of their span of control. And that's where it starts to, I think it definitely has created some concern in terms of folks trying to get ahead of that, and we'll see really how CMS, what kind of remedies they may have for that timing issue, and hopefully they can give them a little bit more clarity to the entities as to whether or not they're going to be deemed significant participation or insufficient participation. And track the rule. Attend our webinars. We'll be on top of it. We'll share as much as we can. But these are some of the areas that we expect there to be a lot of activity and discussion around, and no doubt a lot of people are hard at work on that right now. So great. So Carol, I want to hand back to you. Looks like we have about 8 minutes left. One last thing is that we do have the 5 FAQs about MIPS APMs that are on our website, relatively new. This is how to find it, and you'll see a little bit more detail there and a lot of references to the regulation as well. All right, thanks, Carol.
Can you hear me?
I can.
Yeah, so we've obviously got a ton of questions, just, a lot of information to impart in 52 minutes. Please email Tom at tom@signite. We will not get to a lot of these questions. I've got a few for you to start with, of course. And a lot of people are asking about copy of the PowerPoint and recording. All of that will be delivered to everybody by Monday. Question 1, which is actually, you spent quite a bit of time talking about this today, which is the ACO MSSP Track 1. How is the ACO measured with MIPS? That was obviously, maybe just give a, 1-minute overview of that again.
Yeah, great. Yeah, absolutely. That was certainly a subject of our previous slide. But at a high level, the most important things to understand is first is that for quality, you're not going to have to submit twice. You'll already be submitting the ACO program. However, those quality metrics will be rated for your MIPS quality score, which is separate and distinct from your ACO quality score, because the algorithms have some similarity, but they're not exactly the same, and they're different enough where just because you're doing well on one of the quality scores doesn't mean you're going to do well on the other one relative to your peers or relative to whatever your reimbursement model is, for that particular ACO program. That's probably the biggest takeaway, and then the other is also with respect to meaningful use, or ACI. That as a Track 1 shared savings ACO, you will have to report meaningful use, or ACI, as at a TIN level and not at a clinician level. That could be a big operational change for some people out there.
Okay. Organizations belonging to an APM, do they submit aggregated data from MIPS from the APM as a whole?
Yeah, and we covered that too.
We did.
And again, at a high level, it's really about, in order to understand the various tables, even the one that I showed, and all the tables I showed there at the end there, they all have references there to the regulation, which have tables there, which I basically abstracted from. But the most important thing is to keep that mental model really in mind. It's so important. I don't know if Carol, if you could flash back to the slide that had the layers of relationships, just to kind of flash it up there. I just want to make sure everyone gets another crack at seeing that. And if you have that mental model in mind, then it will make understanding those tables so much easier, because you're
Not
going to
this
understand what to do. No, not where I keep on going. It's the one that where I have all of the arrows, the multiplicity, like the many-to-many relationships. You'll get to it.
The Venn diagram.
Yeah, yeah. Keep on going up. It's the one with. It's like the first. I'll just keep going, and I'll tell you when to stop. And then we'll hopefully take another question or two here. This one. So slide 7. Just show all of slide 7, and then the last kicker there. Yes. So if you really grasp this, then you'll be a lot more empowered to understand those tables in the way that you need to.
All right, so make note of this one, and again, we'll get you the PowerPoint by Monday. Is it better to be in an APM or just on the MIPS track, pure MIPS?
It's a great question. You know, great question. A lot of organizations have been wrestling with that since MIPS was really announced. Multifaceted, and really it can go either way. I think on a practical level, I think all intents and purposes, policy-wise, is to really try to get as many APM participants as possible. Because I think obviously the intent is a very good one, is to get organizations that are really participating in completely new types of payment models that really put greater emphasis on value. I would say the counterbalance to that is MIPS itself also does have many value-based principles in there as well. It's still based on adjusting fee for service, but you know what? A lot of APMs are also based on adjusting fee for service. There's very few that are true capitation in the way that, let's say, Medicare Part C or Medicare Advantage is. So I think it's going to be really interesting to see how things evolve. But really, it's a multifaceted question, often no easy answers. A lot of it is really, around strategic priorities for an organization. They may have very well other types of reasons other than Part B reimbursement to adopt a different way of operating, which may be more consistent with a particular type of APM. And reimbursement is only part of the equation. So our experience in this has been, it's been multifaceted. We've certainly helped some of our clients with that discussion, but it does require a lot of thoughtful analysis and a real kind of cross-functional view to really figure out the full facets of that question.
And make that determination. How will multi-specialty group reporting be affected by APM participation by some but not all group providers?
Yeah, so I believe the question is if you have a TIN, for example, a group, and you have some providers that are in the APM and others that are not, what does this all mean? And I think we have an example I just mentioned, which is the Next Generation ACO program, and the whole reason why, CMS is making providers report individually is because recognition in that program is not all the clinicians that are going to be ready to take on that risk. Because Next Generation ACO is a two-sided program where you're taking downward reimbursement risk, not just upside potential. So I think for an organization in that situation, first they've got to be prepared, obviously, that the providers that are not in the APM are going to have to do full MIPS, and not the constrained MIPS that their colleagues under the Next Generation ACO are going to be able to, are going to have to do. All right, and so that immediately begs the question: how are you going to resource and staff around that? Like, you're going to have basically these two different sets of clinicians, and you have to really manage MIPS differently for those two. And of course, the ones in the Next Generation ACO, if they're significantly participating, then they don't have to worry about those providers having to do MIPS as well. But again, for the reasons I mentioned, that may not be the case, depending on the situation of the entity and to what extent they've been able to really get their payment count or their payment amount. The patient count or the payment amount threshold high enough. But the last thing around that is that remember that with MIPS you have the ability to choose to report MIPS as an individual provider or as a group. And I'm talking about full MIPS right now, full MIPS. And so I think an interesting question for a group like that is if you have partially Next Generation ACO and you have these non-regular full MIPS clinicians, the fact that you have some ACO clinicians mixed in there, it may very well strongly impact for your full MIPS clinicians whether you want to report those folks as individuals to MIPS or as a group. Because as a group, their TIN is in a way muddied up by the fact that they have these other clinicians that are not subject to full MIPS. Okay, so I think that's an interesting question. Again, I don't think there's any really easy answer, but it's certainly a question that I think a lot of the folks in that situation are gonna be asking themselves. Yeah.
Have to wrestle with, yeah. Believe
Yeah.
it or not, we are all out of time, and we hope our attendees today join us on our ABCs of MIPS next month. We'll be getting that information out as to what the topic will be and the details. Tom, thank you so much, and I hope everybody has a great day.
Thank you. Pleasure to be here.
Bye.
Bye.